Welcome to today's Explainer. We're diving into something that is so deeply misunderstood by the general public. We're talking about narcolepsy. Now, you've probably seen those wildly exaggerated portrayals in movies, right? Someone just randomly passing out mid-sentence for comedic effect. But the reality, it is so much more complex, fascinating, and honestly incredibly challenging for those who actually live with it. Today, we're going to completely demystify this neurological condition. We'll look at how it actually presents, the science behind what's happening in the brain, and exactly how it's diagnosed and managed, specifically down in the Australian healthcare system. Let's get into it. Real quick before we jump in, a quick heads up. The information in this explainer is strictly for educational purposes. It's not a substitute for professional medical advice, diagnosis, or treatment. You always want to consult a qualified healthcare provider if you have any questions regarding a medical condition. All right, here's our roadmap for today. We're covering what is narcolepsy, the key symptoms, the 3 types, diagnosis in Australia, and finally, management and support. Part 1. What actually is narcolepsy? To really wrap our heads around narcolepsy, we first have to erase pretty much everything pop culture has taught us. Fundamentally, narcolepsy is a chronic, lifelong neurological disorder. The absolute most crucial thing to understand here is that it's characterized by hypersomnolence, which is just a medical term for excessive sleepiness, and the brain's complete inability to appropriately regulate its sleep-wake cycles. Let's be totally clear, this is not a behavioral issue. It is definitely not laziness, it's not a lack of motivation, and it's not just a side effect of someone staying up too late on their phone. It is a very real, physical, neurological failure happening right inside the brain, specifically involving the hypothalamus, which basically acts as the boss of your nervous system. What's actually wild is how common, yet completely invisible, this condition is. Get this, it's estimated that there are between 6,000 and 12,000 Australians currently living with narcolepsy. But here is the truly heartbreaking part. Because awareness is so incredibly low and the symptoms are so often misdiagnosed as things like depression or even ADHD, a lot of people go entirely undiagnosed for anywhere from 5 to 14 years after their symptoms first start showing up. That is a massive chunk of someone's life to be struggling without answers. Moving on to part 2. Key symptoms. So what does this disorder actually look like day to day? Well, doctors often refer to the classic tetrad of narcolepsy symptoms. It's like a 4-part puzzle. We've got excessive daytime sleepiness, cataplexy, sleep paralysis, and hypnagogic or hypnopompic hallucinations. Now, just to clarify, not every single patient is going to experience all 4 of these. It varies, but there is one symptom that is absolutely universal, and that's excessive daytime sleepiness. Excessive daytime sleepiness, or EDS, is present in literally 100% of narcolepsy cases. And understanding this symptom really puts the severity of the whole condition into perspective. EDS is not just feeling a little drowsy after eating a big carb-heavy lunch. It is an overwhelming, completely irresistible urge to sleep that just hits you like a freight train, totally regardless of how well you slept the night before. To put that into perspective, sleep experts compare the sheer exhaustion of untreated narcolepsy to how an otherwise healthy person would feel if they were forced to stay awake for 48 hours straight. Seriously, imagine trying to drive a car, do your job, or just have a normal conversation while feeling that level of profound exhaustion. That's what leads to those sudden sleep attacks that can literally happen mid-sentence or mid-activity. And then we have cataplexy. This is perhaps the most unique and probably the most misunderstood symptom of them all. Cataplexy is a sudden, brief loss of voluntary muscle control. The really terrifying thing for the person experiencing it is that it's triggered by strong emotions, and usually it's the positive ones. We're talking intense laughter, excitement, joy, or even surprise. A patient's knees might suddenly buckle, their jaw might drop open, or they could suffer a complete, full-body physical collapse. But here is the kicker. Unlike a seizure, the person remains completely conscious and totally aware of their surroundings the entire time. They just can't move. Because it's triggered by positive emotions, some patients actually condition themselves to suppress laughter or joy altogether just to avoid an attack. And you can only imagine the massive toll that takes on a person's mental health. The final 2 symptoms of that tetrad we mentioned, sleep paralysis and hallucinations, are actually what doctors call REM sleep intrusions. Think about a normal brain. You usually progress through your sleep stages pretty gradually, right? Well, in a narcoleptic brain, those boundaries are completely shattered. REM sleep, which is your dreaming phase, can rapidly intrude straight into waking life. This causes sleep paralysis, where the person temporarily literally cannot move or speak when they're waking up or falling asleep, because the body is basically applying the normal muscle paralysis of REM sleep at the completely wrong time. It also causes hypnagogic hallucinations. These are vivid, intensely real, and often terrifying dreamlike perceptions that just bleed directly into waking consciousness. Okay, part 3. The 3 types of narcolepsy. So understanding the symptoms is just step 1. Next comes the official classification. There's a very clear line drawn between the primary types, type 1 and type 2. Type 1 is narcolepsy with cataplexy. It's actually caused by a catastrophic autoimmune destruction of hypocretin, which is also known as orexin. Hypocretin is basically your brain's most crucial wake-promoting chemical. In type 1 narcolepsy, the specific neurons that produce this chemical are almost completely wiped out by the body's own immune system. Type 2, on the other hand, does not feature cataplexy, and the patient's hypocretin levels usually test completely normal. Generally speaking, type 1 is considered more severe, though both obviously have a massive impact on a person's day-to-day life. We should also quickly touch on secondary narcolepsy. While types 1 and 2 are primary neurological disorders, secondary narcolepsy is actually caused by external physical damage to that hypothalamus we talked about earlier. This could be from something like a brain tumor, severe head trauma from an accident, or an illness like multiple sclerosis. The symptoms look very similar, but the root cause is distinct: structural damage to the brain. Section 4. Diagnosis down in Australia.
So, let's say someone is experiencing these symptoms. How do they actually navigate the Australian healthcare system to get some help? I'll tell you right now, the diagnostic journey is rigorous. It kicks off with a clinical evaluation, meticulously logging sleep diaries, and taking something called the Epworth Sleepiness Scale questionnaire. But that's barely scratching the surface. Crucially, a simple home sleep study, absolutely not sufficient to diagnose narcolepsy, and definitely not enough to access the subsidized medications needed to treat it. The patient has to go into a specialized sleep lab for an overnight polysomnography, or PSG. This measures their brain waves, breathing, and muscle activity to ensure their sleepiness isn't just being caused by something else, like sleep apnea. And then the real test begins the very next morning.
Just to give you a real-world look at this process, a patient information form from St. Vincent's Hospital in Sydney outlines the exact requirements for a multiple sleep latency test, or MSLT. This right here is the absolute gold standard for proving a narcolepsy diagnosis. So how does this MSLT actually work? During the day, the patient is given 4 or 5 20-minute nap opportunities, spaced exactly 2 hours apart. The medical team is watching and measuring 2 specific things: exactly how fast the patient falls asleep and how fast they enter REM sleep. Let's compare. A normal, fairly well-rested person might take 12 to 14 minutes to fall asleep during a daytime nap, and they definitely won't enter REM sleep. But for a narcolepsy diagnosis to be confirmed, the patient generally falls asleep in under 8 minutes on average, and this is the crazy part, they abnormally transition straight into REM sleep during at least 2 of those short daytime naps. And finally, part 5, management and support. So once a diagnosis is finally secured, the focus shifts entirely to solutions for what is currently an incurable condition. The absolute foundation of managing narcolepsy is behavioral and lifestyle therapy. We're talking incredibly strict sleep hygiene and keeping extremely regular hours. Shift work is strongly advised against because it just totally wreaks havoc on an already broken circadian rhythm. Lots of patients manage their daytime sleepiness by scheduling precise, timed naps throughout their workday. And for those with type 1, learning to manage or anticipate their own emotional triggers is a daily, exhausting reality just to prevent those cataplexy attacks. But let's be real, lifestyle changes alone are rarely enough. And that brings us to pharmaceutical support. In Australia, the Pharmaceutical Benefit Scheme, the PBS, subsidizes several crucial medications, but only if they're prescribed by a highly qualified sleep physician or a neurologist. For that excessive daytime sleepiness, wake-promoting stimulants like modafinil and armodafinil are your frontline defense. For managing both the sleepiness and the cataplexy, there's a medication called sodium oxybate. Now, this is a highly restricted Schedule 8 medication in Australia, which means it requires special prescriber permits, but the Australasian Sleep Association strongly supports using it for severe cases. On top of that, standard antidepressants like SSRIs or SNRIs are frequently used off-label. Why? Because they actually suppress REM sleep, which helps control those cataplexy attacks. But meds are really only half the battle, right? Navigating this lifelong, essentially invisible condition requires deep, ongoing community support.
Surprisingly, narcolepsy is not currently considered a recognized disability under the NDIS here, which leaves so many patients fighting tooth and nail for adequate support. That's exactly why local resources are so vital. Organizations like NODSS provide incredible advocacy and community connection. Multidisciplinary care involving psychologists and occupational therapists is also super highly recommended to help patients adapt their schools and their workplaces to fit their unique needs.
I absolutely love this quote from the Brain Foundation because it brings a message of real, tangible hope to the table. Most individuals with narcolepsy enjoy a near-normal lifestyle with adequate medication and support from teachers, employers, and families. Did you catch the key word there? Support. The condition can be incredibly debilitating when it's untreated and ignored, absolutely. But with the correct diagnosis and a truly supportive environment around them, people with narcolepsy can thrive and lead incredibly fulfilling, successful lives. So here's what I want you to think about as we wrap up today. Narcolepsy is largely an invisible condition right up until an attack actually happens, and that leads to some incredibly harsh judgments and a lot of stigma. When someone is really struggling with profound daytime sleepiness, our absolute first instinct shouldn't just be to call them lazy. Knowing what you know now about the physical, neurological failure of those sleep-wake cycles, how can we better support individuals with invisible neurological disabilities in our own workplaces and schools? It all starts with awareness, and I really hope this explainer has helped build a bit of that for you today. Keep learning, keep asking questions, and I'll catch you in the next one.